What are the key trends, priorities, challenges going on in the Brazilian healthcare system that you as a country are focused on today?
The Brazilian Constitution of 1988 created the what we call the Unified Health System, SUS, and it is really a landmark because it states that health became a right for all people in Brazil and a duty of the state. This is a very comprehensive and trying to be universal and equity health system. And of course, we have also what we call the supplementary health system. It's a private system which accounts for around 25% of the Brazilian population. It's important to note that the public system, the SUS, covers all Brazilian population. It's the largest public health system that provides free of care from primary care to hospitalizations and complex treatments for all Brazilians.
Welcome to the Analyzing Healthcare podcast brought to you by Scale Community. Scale is a global healthcare-focused member network where healthcare leaders come to connect, learn, share ideas, and shape what's next in our evolving healthcare landscape. To take advantage of all that Scale Community has to offer, from expansive content to virtual and in-person events to interactive peer networking opportunities and more, check out Scale Community at www.scale-community.com. Membership options range from free to paid, so if you enjoyed today's discussion, please take a moment to sign up for your preferred membership level. All right, welcome to the next Scale Community Technology and Innovation podcast. Today we will be exploring our theme of global healthcare, where I'm joined by Professor Dr. Jefferson Fernandes. Welcome, Jefferson.
Thank you very much, Jason, for inviting me to participate in this wonderful podcast series.
So today we'll be exploring Brazilian healthcare with Jefferson, and Jefferson brings a whole career focused on the Brazilian healthcare market, a neurologist by training, and really a core focus on telehealth, telemedicine in many forms. Director of Education for the International Society for Telemedicine and E-Health, Vice President of the Digital Health Commission for the Brazilian Medical Association. And just for reference, the Brazilian Medical Association has about 140,000 provider members, the second largest medical association behind the American Medical Association in the Americas. Co-coordinator and key knowledge in digital health immersion course in Lisbon, Portugal. So among other roles, exploring, innovating, and implementing telehealth initiatives at large scale in the Brazilian market. So quite a rich background, and very much looking forward to the conversation.
Thank you very much.
So, as we do in our global healthcare podcast, I'd like to begin with a little bit of background and introduction to the Brazilian healthcare system. And so before we get into telehealth specifically and maybe set the stage for why telehealth is particularly relevant, but what are the key trends, priorities, challenges going on in the Brazilian healthcare system that you as a country are focused on today?
Yes. Well, we have to understand that the Brazilian healthcare system has undergone major transformations in the past decades. The Brazilian Constitution of 1988 created the what we call the Unified Health System, SUS, and it is really a landmark because it states that health became a right for all people in Brazil and a duty of the state. This is a very comprehensive and trying to be universal and equity health system. And of course, we have also what we call the supplementary health system. It's a private system which accounts for around 25% of the Brazilian population. It's important to note that the public system, the SUS, covers all Brazilian population. It's the largest public health system that provides free of care from primary care to hospitalizations and complex treatments for all Brazilians. And there are some characteristics among the evolution of both systems. Usually the private system, there are health plans that are provided in the majority from employers to employees and their families. And as I mentioned, 5% is around roughly 50 million people. And there's some kind of not really an integration, but something that if a person has a health plan but uses the public system, the health plan has to reimburse the costs for the public system. So it's a choice, and usually, of course, the cost is lower. The expenses are lower in the public system, but it's something that tries to not overload the public system. And it's nice, Jason, to call attention to the three main principles of the unified health system. As I mentioned before, it's universality, so access for everyone, comprehensive from everything to primary care to high complexity procedures, and equity. Policies aim to reduce the health inequalities. And the supplementary or the private health system is regulated by the National Agency of Supplementary. So this is some of the characteristics of both systems. To sum
But
up,
on the
yeah,
private
sure.
side, are patients who have private insurance utilizing the same facilities? So you can go to the same hospital, but one patient might have public coverage and the other might have private coverage, or are the private insurance patients going to separate facilities?
Yeah, usually they are separate facilities. There are some hostels, teaching hostels or philanthropic hospitals that might have both. So, but usually the health plans goes to private hospitals. Some of them are philanthropic, but sees only private patients in a special law that was published 15 years ago, or maybe less, that philanthropic hospitals can provide care for public system patients.
When you look at that system, so universal coverage, comprehensive universal coverage with 25% or 50 million individuals covered on private supplemental plans, how is the system functioning? What are the things that are working successfully at a macro level? What are the things that are challenges or areas for improvement in the Brazilian healthcare system?
Yeah, talking about the public system, the access to primary care through the what is called the family strategy, primary care for the family strategy is something very, very interesting because there are these primary care facilities where there is a team of professionals, physicians, nurses, and we have what we call the community health workers. And these community health workers, they take care of a certain number of families, and they visit these families in their homes to understand how things are going on regarding their treatments, their needs. They come back to the primary care facility. So this is something very interesting. It's something that was created mirroring the national health systems, the NHS in England, but it improved. So the health community workers are really something that differentiates. It could be a kind of example for other countries to bring the health care close to the patient at home or at the primary care physician.
And
Of
so,
course, we have, yeah.
as a result of that, what are some of the outcomes that you benefit? Is there a high preventative care rate, a
Yeah,
high vaccination rate? What are some of the health outcomes that you get as a
yeah.
country based on that system that you have in place?
Yeah, vaccination. No, this there is an universal program of vaccination which has higher rates of adoption of adherence to these programs by families, by children, and this is something very important. Other programs such as taking care of some chronic disease such as hypertension and diabetes with free medication for these sorts of diseases is something that really increase the approach of not only primary care but primary prevention, but also for secondary prevention. So of course there are some difficulties. Let's say access is different from more rural remote regions. It's easier in urban, but even when you have large cities, capitals and so on, it might have some difficulty in accessing because too many people, not enough primary care units. There are also some units towards specialties, and there are also what we call the not really emergency but first care units as well that refer to hospital emergencies. But as there is not really enough access to all these primary care units, people sometimes go to the hospital emergencies for things that could be solved in the primary care facility. So this is something that is being managed. And of course, health and telemedicine, triage system, digital triage systems are starting to help this distribution of patient to send the right patient to the right place at the right time. So this is something that is growing.
So, talk about the divide or the differences in healthcare across the country. 200 plus million people, top 10 population in the world, and quite a large country with diverse geographic composition. I imagine that the healthcare needs across the country vary. I imagine that the healthcare system varies across the country. So, firstly, is this universal coverage, is it driven at a national level, or is it driven at more of a provincial or state level? And how does Brazil handle the different needs of the different populations across the country?
Yeah, good question, Jason. Of course, with this population of 210 million people and plus, it's not easy to manage and also to provide enough financing for all these systems. So we have these disparities. We have the South region and Southeast region where we have richer states, more adequate public health system and also private health system. Northeast and North, the difficulties are greater. You can imagine the Amazon region, it's a large region, so sometimes to reach some populations, you need to do it by boat. And so this makes a difference depending on the region that people live. And within the regions, it is if they are close or far to more populated centers. So there's this access difficulties regarding this. And the system, the public system, actually it has three levels: the federal, the state, and the municipality. So these three levels have to work together. Of course, there are challenges, there are difficulties, but the provider in the front of the healthcare is the municipality. The state is responsible for several other aspects, and the federal government has more kind of a technical approach, developing health policies, also providing no financing. The federal system, the federal government uses a kind of 1.7% of all GDP for the public health sector, which is less than we need. It is underfinanced.
What
But the
was the
state,
percentage?
1.7% of the GDP. So it's
One,
lower than
1 point.
1.7. It's lower than other countries. Yeah. But the state and the municipality, each they have to apply kind of 12 to 15% of their tax incomes to the public system. And they have to work together, to try to optimize this care. So, as I mentioned, the family health strategy and the primary care facilities, they are managed by the municipalities. The state can support some of these the basic units, some hostels, some state hostels. So we can have some hostels from the municipality, some hostels from the state, and some federal hostels as well. So the challenge is to integrate everything. So this is something that is being evolving. Of course, there is a tremendous progress since 1988, but still we have to reach better access and improve the equity for the needs of the population nowadays. But the direction is of improvement. The financing, management are things that is needed. And also this, as we know, even developed countries such as Canada or England or Portugal, so uh, we have a very good relation and straight relation with Portugal. They cannot manage the public health with in terms of financing. Uh, what is growing in Brazil is the public-private partnership, as it happens in England, it has happened in Portugal. So, for example, there is a very interesting program, successful program, that started in 2009 called the Program for the Institutional Development of the Unified Health System, were private philanthropic hospitals. And to be called philanthropic, there are a certain number of criteria that they have to achieve, excellency and so on. They have some tax exemptions, but they have to apply 100% of these exemptions in programs towards the public health systems, guided by the Ministry of Health. So this proved to be something that is an extra budget from the federal budget, from the state and municipality budget towards primary care. And this is improving a lot. And now with the, let's say, the explosion of digital health, this approach of having health techs also supporting the public system, being paid the amounts that the public system can pay, and these health techs bet on the scale of their solutions. It's something that, tackling the access and the quality of care. But these aspects are really bringing more healthcare for patients, and we still have to progress because you mentioned in your first comments that we have this situation of infectious disease in some regions. It's true for the Amazon region, for the center-west of Brazil. But our main problem as a country are the non-communicable chronic diseases. We have two problems. The main one is now chronic diseases, but we still have some regions where infectious disease are really a challenge. So we have to deal both of this.
Understood. Is the rate of private insurance at 25% of the country, is that fairly constant, or are you seeing a growth or decline in the percentage of private insurance?
Yeah, we had a few years ago a small decline on that because of the costs of health. I used to have lots of individual health plans, but the health insurance companies decided to uh, be more open to collective plans or plans from companies. So this reduced a bit, but now it's growing. It's growing again, and it's something interesting because it's not replacing the unified health system, but it's complementary to the health system for those who can pay for the health insurance. And as I mentioned, they are paid mainly by employers to employees and their families. And one question is the cost. Month payment is increasing. There's this discussion of what now exams or treatments are allowed to are paid by these health insurance operators. The National Supplementary Health Agency, they have kind of role of what exams or what treatments should be allowed to be paid, or it have to be paid by health plans. But the incorporation of new technologies and new treatments is something that takes some time, and it brings some kind of legal action from patients to have access to treatments that are already being, let's say, scientifically based, but still are in the process of being approved by the National Health
Yeah.
Agency.
Look, from your comments, it sounds like a very well-intentioned system. It sounds like a very
Yeah.
ambitious system, right? So well-intentioned, universal coverage, the community centers that really bring patients into the system and engage with them, both at these community clinics as well as in the home. Ambitious because that's a lot to do in the context of the funding levels that you mentioned, which stand out as quite low on a relative basis. And that's ambitious to offer to a country as large as Brazil and as diverse as Brazil is. So it's not surprising in that context, and I think it's a good segue that my understanding is Brazil is looking to telemedicine, telehealth as a strategic direction for the country, probably thinking about that as a way to expand access, a way to deliver care and make good on this well-intentioned commitment to the population to deliver comprehensive care on a public system. So with that context in mind, would love to hear a little bit more about the telehealth, telemedicine strategy from Brazil and your involvement in it.
Right. Yeah. Okay. So there is a successful program of telehealth that has started around almost 15 years ago. It's called the Brazilian Telehealth Network. It's mainly it is the provision of interconsultations, meaning that as specialists providing support for primary care physicians to manage the patients. Let's say a patient with diabetes that is being difficult for the primary care physicians to manage. So he can do a consultation with a specialist, and this specialist helps him or her to provide this care. These specialists are located usually in teaching hospitals, university hospitals, where they have a special program. They are supported financially by the Ministry of Health. And with that experience, it has been shown in several scientific publications that one of the aims is being achieved, which is to reduce the waiting list to specialists and also to improve the quality and the outcomes for the patient, letting the primary care physicians feel confident that its or her management is done properly with the support of a remote specialist. So I give you an example for neurology, rheumatology, endocrinology. Sometimes the waiting list could be 1 year or even 1.5 years. So in several places where this program was implemented, it reduced to a waiting list of 2 or 3 months, even less, depending on the city, on the location. So this is something that is being spread. Of course, the limitation is to finance all these programs, but it is being spread because it is a successful program. And the public health system created what is called the National Secretary of Information and Digital Health. It's something very new, which is responsible for developing policies and creating programs and giving the technical support to improve the digital health or to foster the digital health transformation. So we have the strategic plan from 2020 to 2028, which includes what you call the Digital Data National Network, where it's a process of interoperability, where the clinical data of the patient would be accessible in any primary care facility in the country. And also trying to, a further step is to correlate or integrate it with the public hospitals. So this implies in financial support for the internet infrastructure in Brazil, which is growing, mainly in regions such as the Northeast or the Amazon region, the North region. And of course, providing hardware for the basic care, primary care units, proper hardware, computers with memory and internet bandwidth. So this is something that is being increasing. And also starting training professionals to use not only these technologies such as telemedicine or telehealth, because this is something very important. This is not only my opinion, but most of the professors that are working in education, as I am, that telemedicine is not a tool, is a method of care. And as a method, it should be learned. So this is something that is important to teach people, and it can go deeper on this topic if you like.
I think in the post-COVID world, where we are much more familiar with and used to the idea of telehealth in the broader healthcare system. Give us a sense for Brazil's adoption of telehealth. So the average patient is likely to interact with telehealth anytime they see a specialist, or what scale has telehealth been rolled out in Brazil?
Yes, well, you have to approach by these two systems. The public system, teleconsultation, patient direct to physician, is something that is just starting. But in the supplementary system, is something that is being developed very quickly. I need to mention that teleconsultation, physician direct to patient, wasn't allowed in Brazil up to the pandemic. This was something that was, something that we were expecting for years. I'm involved in this area for many years and a member of the American Telemedicine Association for AIDS and also from other institutions in Europe. And it was really, we were struggling to have this approval that the teleconsultation approval. That was something that the Federal Medical Council was refraining, for several reasons, very interesting reasons, no corporate position and so on. But anyway, when the pandemic came, this had to change. And I was working previous to the pandemic with a federal deputy, Mrs. Adriana Ventura, supporting her with the technical aspects of medicine, teleconsultation mainly, because telediagnosis, teleinterconsultation was allowed, but teleconsultation was not. And then came the pandemic, and we were ready, almost ready with the bill that was going to be proposed for the Brazilian Congress. So in 1 month, the Congress, our parliament, just approved that. So teleconsultation started to be used in Brazil, and there was, of course, as any other country, a tremendous growth of that. And this growth is keeping pace even after COVID. Of course, there is still a long way to go. The question is, relates to the health insurance companies or having providing these services, most of them do, and also the public system to start to use it more. So it's interesting because it's a kind of open market, because we need more companies, we need more devices, we need more softwares that really provide what is needed. As people say from startups, to understand the pain, the need, and then offer the solution that efficiently provide that. Because this is something else. Sometimes you have these digital solutions that do not prove that what they say they deliver is really being delivered. So this is another topic to discuss. But anyway, so this increase in use of teleconsultation is something that will grow more. And of course, we still need to teach physicians how to do it properly. We still need to overcome the resistance from many, I would say, physicians from other times that were analogic to go to this. But a hybrid model is people being seen in person and people being seen also remotely. So this is something that is increasing. The payment aspect is really something that is interesting because usually we have this parity. The health plans usually they pay the same amount of an in-person. So this is good. Another achievement that we made with the bills and the last one, which is not only telemedicine, because in Brazil we separate telemedicine is for physicians and telehealth is for all professionals, including physicians. So telehealth is a kind of umbrella term, and digital health is a larger umbrella, and telemedicine is for physicians. So the bill that was published near the end of COVID, it was the law number 510. It's for all health professionals. This allows us to have the legal support and also the professional councils adapted to it, so it's impossible for every country. And it's interesting because different from other countries such as the US, a physician doesn't need to be registered in other states to provide care for a patient in other states by telemedicine. If you're going to do it in person, you need to be registered in a second register. But telemedicine, you can see patients from anywhere in Brazil. So this excludes the barrier of geographic limitation. So this is something that is good. So it's something that is go on. And now physicians that finish their medical school, they are digital born. So this is something that comes in their DNA.
I want to go back to something that you said. I think I understood, and I just want to clarify. It sounds like Brazil back to 15 years ago, so 2010, let's say, has been experimenting with telehealth, telemedicine, and did so by forming certain associations and committees within the public system. It sounds like post-COVID, there have been legislation that's now institutionalized the ability to adopt telehealth, telemedicine, but it sounds like adoption and implementation has actually been faster on the private side. You mentioned that the public side is sort of early innings, and the private healthcare market is a more rapid adopter. So firstly, I wanted to make sure I understood that fact correctly about the private sector. And secondly, I would love to get your thoughts on that. A system that is very much geared towards public healthcare, and yet progress in this area, at least to the extent that the introduction of telehealth, telemedicine is a positive, is coming faster on the private side. And I wanted to get your thoughts about, whether you agree with that and what the implications are of seeing that progress on the private side.
Yes, sure. So just to clarify, teleconsultation, physician to patient, was allowed since the beginning of COVID. The second month of COVID, it was allowed. But to touch in a very interesting aspect, because as it happens, not only in the public system, but also in the private system, culture is something that is of tremendous importance. Of course, the private system needs to be more agile in finding solutions for what they are providing. So they also have more an entrepreneur approach, and also they need to find solutions that do not increase too much the cost, and seen as an investment, not as a cost in the case of telemedicine. And also they have to provide care for patients. So how to do it if
Yeah.
you cannot see the patient. So that's why the adoption was quicker. In the public system, this was a tremendous bottleneck, sorry, and during COVID, but it started to grow. And again, culture is the word. So the decision makers, policy makers, first have to understand what is telemedicine, telehealth, and digital health, to understand their benefits, and then to build up strategies, to build up action plans, and really implement that to get all the benefits. Of course, knowing also the limitations. So this is something that took time. It's taking time. And the second aspect is financing. How to deal with this new approach technology, how to pay for it. So, and of course, all the data that we have internationally, that it is telemedicine, telehealth are cost effective, though is something that is pushing. And the mayors, mainly the municipality sector of health, they have the hot potato in their hands, how to care for their population. So they started to hire private companies or private startups to provide, telehealth access for patients, and of course paying the amount of the public system that is much lower than in the private system. But these startups or companies understood that they have a kind of purpose, and also scale is something that would compensate these different aspects. So culture, as Peter Druck said, now if you don't have culture, culture will eat a strategy in the breakfast. So this is one aspect. And still in the private sector, private hospitals or health insurance companies, there is still something to be changed. So, and also just the ability to manage that. So the private sector developed this ability. So that's why, yeah, please go on.
Yeah, I would be curious to hear more about the Brazilian Medical Association and what role the association has played in the adoption of telehealth. Is the provider association promoting it? Is there reluctance, concern? Are there initiatives going on to increase adoption? So what role has this large
Yeah,
association played?
yeah, sure. So we trying to do since the beginning of COVID, to help physicians to learn about the use of this technology of teleconsultation, telehealth, how to do a teleconsultation, because you need to. It's a different approach than the in-person one. You need to show to do something that the patient feels comfortable and confident to use. So we start doing some activities, educational activities, together with state medical associations. And the main one was the Medical Association of São Paulo, which is the most populated state. It's also the richest one. 25% of the Brazilian GDP is in there. The city of São Paulo has 12 million people. So we started doing online courses. I was the coordinator for that. And the first basic course we had, the first group, 1,300 physicians doing this first course. So we started to develop in partnership with different state associations. Then we created this commission, Digital Health Commission, which is I'm the vice president. A colleague of mine, a friend, Rodrigo, is the president. What we're trying to do is to provide information and education for physicians, but always working in partnership, because it's a huge work. We cannot do it by ourselves. And the Medical Association is involved in several other issues. The Brazilian Medical Association also gets involved in the practice of medicine regarding the public system, the private system, protecting physicians, protecting patients, dealing with other health professionals that sometimes want to get into the medical act. So this is something that involved. So step by step, we are trying to build that, and trying to support the state medical associations, which are members of the Brazilian Medical Association, and also the national specialty associations, which are also members of the associations, with what we can provide. And As you mentioned, one of the first things we're trying is to try to reduce the resistance of physicians towards that, and trying to convince the Federal Medical Council that we should change, not refraining from allowing teleconsultations, physicians to patients, and showing that it's for the benefit of the patient, for the benefit of the health systems, and physicians will also be benefited. No, it was the fear first. Some people saying, "Oh, the medical-patient relationship will just be broken, seeing a patient by a screen." No, the evidence was not that, but you have to show this evidence. Or a physician from São Paulo will take care of my patient in my city in the Northeast region. So all these aspects we have to deal and go on. And we did, myself and Rodrigo, we were representing the Brazilian Medical Association and also the São Paulo Medical Association, which is the largest state one, in the Congress, in the Chamber of Deputies, and also in the Senate, lobbying. We went to Brasilia to show to our physicians, federal deputies and senators, the benefits and that they should understand this change. So this was something that we did there, we still do, but we have overcome all of these barriers. So now what we are discussing is artificial intelligence. It's a huge topic. We need no regulation, legislation for artificial intelligence. There is several bills going on, being discussed in the Congress for AI in general. So we are trying to help when the discussion comes to the health, not only us, but also other civilian organized societies. So this is something that is now the big challenge. Now, how to provide a legislation and regulation that allow the growth and the innovation coming from AI, but also protecting people and mainly patients for the potential damage. This is something that is all around the world. All discussions that are seeing. We are looking at the Brazilian government and the Congress is looking for the European Artificial Intelligence Act. We have our DGPR, data protection law, and our data protection law is very similar to the European one. So we tend to follow the European legal approach towards not only data protection, but also towards AI.
And last question I always like to ask is when you look across all the things that we've talked about, what is something that if you can contribute on behalf of Brazil to the global healthcare market, something that you think Brazil does particularly well, that's special, what would that be? You mentioned at the start of the conversation about the community clinics, so perhaps that's it, but would love to hear what that contribution would be from your perspective.
Yeah, I think the first one is the national policy. As health is a right for each person and a duty of state. So we are an example of a middle-income country that is managing to provide free healthcare to all Brazilian population. So this is very important. Once you have this policy, once you have this approach, you can start building up the support, because it's sad to see people that are dying or getting worse from their disease because they don't have a health plan and they don't have money to pay for care. This is really sad. So the first one will be this: the universal care, free of charge, the comprehensive care from primary care to complex, and trying to go towards the most possible equity among all persons. So this is one very important aspect. And it's possible. We are the example, not only us, but we are an example of a middle-income country that no example for developing or for other middle or lower income countries. The second, as you mentioned, is the community health workers. They are really, really helpful because they go deep. They know what's happening in that family. And with that information, what is happening in the house, the relationship, the problems, the social problems, they can have a more integral approach of the family and of the patient. So this is something that even people from the NHS came here. As you mentioned, the NHS was kind of example, not only for us, but for other countries such as Portugal, in the strategy of the primary care. But this is really helpful to decrease the overload of patients going to hospital, approaching the primary prevention, secondary prevention. Of course, you still have a long way to go, but the principle is there, the strategy is there. The question is, or the questions are, how to make it happen. And this is not something easy to do. And as I mentioned, the public-private partnerships is something that is growing and will grow to support these ideas. So this would be something that would call attention. And also in the digital health field, the public system is going on in the interoperability to try to the patient have that, as we mentioned, only one record. Of course, it's not only one, but the access for different systems can be just one. So this is important, not only for the public system, but also for the private system, which is fragmented. Now we have a fragmented system, several softwares, several patient health records, and they don't talk to each other. If a patient goes to another hospital, maybe they have to do the same tests or exams again. So there's a waste of money, and there is a risk for the outcomes of the patient. So this is something that is being done at the national level. It's being obliged for the public system in the outpatient. It's going to be, and this is going in the near future to push to the private sector. Look, if you want for the hospitals that provide care, philanthropic hospitals or other hospitals that provide care for the public system, you need to be interoperated. So this is something that sometimes can need to be top down. So I think this is kind of example. Of course, this interoperability issue is complex, costs a lot of money, and depends much on people. But this is something that people are doing. So the policy, the strategy, the ability to make things happen, the partnerships, the providing of finances, it's something that's important all over the world. These things, universal care, free of charge, community workers, and trying to provide more and more digital support. It's not going to change the structure of the health system, but it can help to transform it. This is one of the things that
I think it reminds me of, I think it's Taiwan that has a universal system, technology system for data interoperability, but very, very few countries have solved for that. We certainly haven't. So makes sense. Jefferson, I really want to thank you for your time and for giving us an introduction to the macro state of the Brazilian healthcare market and the structure of the Brazilian healthcare market, and then certainly how Brazil is leveraging telehealth to advance care in the country. So I really appreciate the time and informative conversation, and thanks so much.
Thank you very much for having me. Good luck, and let's move on.
Thanks so much.
Bye-bye.
Thank you for joining us on Analyzing Healthcare. Stay informed and stay inspired. Don't forget to subscribe and visit scale-community.com to become a Scale Community member. Until next time, keep exploring the ideas that shape our healthcare systems.